So in regards to accurately diagnosing a rotator cuff injury, a rotator cuff tear, Dr. Feely talks about special tests, which are inconclusive. There is no single special test that really accurately determines if there's a rotator cuff tear and whether that tear needs surgery. His favorite test, which I agree with, is what's called a painful arc test. And so if you imagine a person standing up with their hand down by their side, they're typically pain-free. As the arm moves up, once it goes from about 70 degrees to 120 degrees of abduction, there's a painful arc in that range. There's no pain above, there's no pain below. There is a caveat to that test, though. A lot of times patients will say once they get the arm up there, when they start to bring the arm back down, they experience pain. But it's important that you understand from a painful arc perspective, it's not really where the hand is, it's where the elbow is relative to the shoulder. So if my elbow is here, if you were to draw a line that measured this angle, my elbow at my rib cage being 0 degrees, my elbow in line with my shoulder being 90 degrees, it's where that elbow is in the arcing motion that determines a positive painful arc. But let's get into this series of questions about the history related to the symptoms somebody's experiencing, because he has some great information here. So let's start by listening to what he has to say about pain at night.
However, when we go over, we'll go over this later today when we do the physical exam skills, there are some key questions that I ask patients. I ask, is there pain at night? If there's pain at night, that is going to be more commonly rotator cuff problems, especially if they come in with their significant other and the significant other is saying, yes, for the love of God, please fix this because I'm not sleeping well either.
Okay, so the only thing about pain at night is pain at night can be consistent with rotator cuff for sure, but pain at night could also be consistent with a labral tear. A labral tear is something that's a deep, throbbing, aching pain. Depending on the positioning of the person, he doesn't discuss it in this video, but if you're sleeping on the painful shoulder, you're getting compression into the joint capsule. If you're sleeping off of the painful shoulder on the other side, you're letting that arm kind of swing around in front of you, or you're letting it drop back behind you. You're going to be stressing different structures that could be producing pain that are not the rotator cuff. And then, of course, the concern with pain at night is there are certain other complexities and comorbidities that are associated with referred pain to the shoulder at night, including cancer, tumors, things like that. And then there's, of course, the cervical spine positioning. Certainly, if I'm laying on the painful side, my head is side bend. If I'm using a small pillow, that could be producing compression in the cervical nerve roots that would refer pain to the shoulder. Or if I have too much of a pillow and I'm leaning the other way, I could have referred pain out for that as well. So pain at night is a symptom, is a sign, but it's not the only one. And that's why he gives us a list of other things that we have to check off the box. So let's go to the next sign.
And pain with overhead activity is a very good question to ask your patients with potential rotator cuff problems, because if they can get their shoulder above their head and they're having pain bringing things down off of shelves or holding their arm up above 90 degrees, it's very likely that that's going to be a rotator cuff problem. And you can say,
and that's what I see in the clinic as well. Pain with overhead activities, workers that do a lot of overhead activities, from electricians and painters, throwing athletes, or anybody that's doing a lot of stuff with the arm in the overhead position, mechanics. These are things that are consistent with rotator cuff pathology, damage to the rotator cuff. And so a common complaint is you might be able to lift something up, but then bringing it back down. When the arm goes from that overhead position down with the eccentric motion, that's where somebody gets a sharp episode of pain. Once the arm is down, it might be a little bit throbby for a bit, then goes back to baseline.
Say, well, why not arthritis or frozen shoulder? Well, those patients simply can't raise their arms up that far. So they say pain with overhead activity and they put their hand like this, it's probably not a rotator cuff problem.
And again, that's true. With severe osteoarthritis, with a severe frozen shoulder, the arm doesn't have the mobility to get into the overhead position. So patients wouldn't even know if it was painful overhead because they're not doing that. So if you're able to do that, that kind of rules out some of the other complexities and leaves us with fewer options back to rotator cuff tear.
Is there pain at rest? I mean, it's unlikely to be a rotator cuff problem. Patients with pain at rest tend to have chronic inflammatory conditions that's more likely associated with arthritis. And you think about your patients with knee arthritis, that's what they say. It's a deep, achy pain in their knee or in their hip, no matter what they're doing. It gets worse if they're more active, but it's always kind of there with them. So for
pain at rest, again, we need context around that. So if you just did a whole bunch of activity and you stop and now you're resting to recover and it's painful, it makes sense that the activities generated the pain and now there's a residual pain that's going on. But what he's talking about is maybe you've been sitting idly, watching your favorite TV show, doing some work on the computer. At some point, the pain should resolve. And when you think of the rotator cuff, remember, it's the musculature, the tendons that attach the muscles to the bones. So those are under stress when they're being used, when you're actively moving or doing something against resistance. So when you're not using the rotator cuff muscles, just sitting at rest with the arm supported, there should not be increasing or consistent pain.
Patients with rotator cuff problems, they don't typically have pain at rest, and the pain is located laterally. So about once a week, I have a patient says, it can't be my rotator cuff because it's the side of my arm, or they kind of grab their whole arm. That, to me, makes me think more of rotator cuff tears rather than biceps or AC joint problems.
And that's probably the most important part of this segment is when patients come in with true rotator cuff pathology, where they localize the pain is super specific and it's very consistent. If somebody comes in and they say, my pain is radiating down the outside of my shoulder, very consistent with supraspinatus, which is that tendon right there, very consistent with rotator cuff tear or pain. If they come in and they say, my pain is in the front of the arm, I can't reach into the back of a refrigerator, I can't tuck my shirt into the back of my pants, that is more consistent with a biceps tendinopathy than a rotator cuff. If they come in and they point right up here where the collarbone, here's my collarbone, attaches into the shoulder blade, the acromion process, that's more consistent with AC joint dysfunction. True rotator cuff pain, most often, but not always, will produce referred pain on the outside of the arm. I usually say not totally around to the outside, but kind of this 3/4 around to the outside. It's very consistent. And so when you put this bag of symptoms together, you say, okay, I can get overhead, but I've got pain when I'm overhead. I've got pain at night when I'm trying to sleep. I've got pain in this lateral portion of the upper arm. All of these things are consistent with rotator cuff problems. I have full range of motion, but pain with resisted motion. I don't have pain at rest. These are consistent with rotator cuff specifically, as opposed to other tissues. So guys, that's the end of this segment. Join me in the next segment and we'll move on with Dr. Feely's presentation.